Hello future doctors, how are you all? Welcome back to Medsteps Internal Medicine Series episode 11. So today we are going to discuss about very high yield topic, that is pulmonary embolism. So myself, I'm Dr. Anand, final year medical student. So without time waste, let's begin. Pulmonary embolism. What it means? Pulmonary means it's related to some lungs. Embolism means something happening with thrombus or embolus or blood clot, and it will go to one place to another place. So that thing we call embolism. Anything like water bubbles formed because of air or because of thrombus, we call that is embolism. Okay. So if you're seeing definition, pulmonary embolism is a condition in which one or more emboli, usually arising from a thrombus, blood clot, formed in the veins or rarely in the right heart, are lodged in and obstruct the pulmonary arterial system. So pulmonary embolism is the obstruction of pulmonary arteries by an embolus. Okay, so most commonly a blood clot originates from deep venous thrombosis. Okay, deep veins of lower limbs, because then we can see deep venous thrombosis. Then after it will lead to, first of all, we can see DVT. Then after it will start from femoral vein. Then after we can see it will go to inferior vena cava. Then after it will go to right atrium. Then right ventricular. Then after pulmonary artery. Okay, so like that it will spread and it will go. So that's why we call this pulmonary embolism. Okay, so now we called one spectrum we called VTE. VTE means venous thromboembolism. This venous thromboembolism spectrum means we call first patient will get deep venous thrombosis, then after the patient will get embolization, then after it can lead to pulmonary embolism. So that thing we call venous thromboembolism spectrum. Okay, pulmonary embolism can be acute pulmonary embolism or chronic thromboembolic pulmonary hypertension also we can see. So how patient will get pulmonary embolism? If you're seeing pathophysiology, you can see here okay. So if you're seeing pathophysiology, you can see here first of all we have some risk factors. Because of these risk factors, patient mostly can get pulmonary embolism. So the risk factors will be like deep venous thrombosis, okay, and previous history of DVT or pulmonary embolism, then after surgery, then after obstructs you can see late pregnancy, postpartum cesarean, and active cancer, immobility, increasing age, estrogen, or combined oral contraceptive pills using hormonal replacement therapy. Because of more amount of estrogen, the blood will become clot, and obesity, and some significant comorbidities like heart diseases, metabolic, endocrine, neurological disability. So these are the things can cause these are the risk factors of pulmonary embolism. Here what will happen whenever patient have pulmonary embolism, because of these risk factors, the patient will form venous thrombosis formation. Then after the clot will detach from that endothelial layer. Then after it will travel through venous system. Then after it will go to right heart. Then after pulmonary artery obstruction, you can see. Then after reduced pulmonary blood flow. Then after you can see ventilation perfusion mismatch. Then patient will get hypoxemia, and right ventricle will get too much strain. The patient will get shock, and if patient have massive pulmonary embolism, the patient can get death also. Okay, so here we have one triad we called Virchow triad. Virchow's triad. In Virchow's triad, we can see venous stasis. Next we can see endothelial injury. Next we can see hypercoagulability. So patient will get venous stasis if patient immobilized. That means if patient have any surgery, recent surgeries, the patient will get venous stasis. Next, we can see endothelial injury because of trauma or because of surgery, and hypercoagulability because of cancer or because of pregnancy. Okay, so here, what are the main source patient will get embolism and why? We can see here first one, deep venous thrombosis. Okay, deep venous thrombosis is like most common source of pulmonary embolism in the lower limbs, mostly femoral vein. Next, we can see tumor. Most commonly, like we can see prostate and breast cancer can cause embolism. And fat embolism, we can see whenever the femur or hip bone fractured. Long bone fracture means that most commonly after fracture, patient will get atrial fibrillation because of this fat embolism. Next, we can see amniotic fluid in pregnant women. We can see sepsis can cause tricuspid valve endocarditis. If we are injecting any illicit drugs, intravenous drug abuse, then the patient can get pulmonary embolism. And foreign body during intravenous drug use, okay, and broken catheters if patient used, or guide wires or vena cava filters, these are things can cause pulmonary embolism. Okay, so next you can see here. Yeah, next, air also can cause pulmonary embolism. We can see in focused thrombotic embolism. When we are discussing that time, we can discuss this thing. Okay, so next here we already covered risk factors. So next we have some types of embolism. The types we can see, we have some types of embolism. In the types, first of all, we can see here that is massive pulmonary embolism. So this massive pulmonary embolism have like it's according based on severity, we have to differentiate. So in massive pulmonary embolism, we can see hemodynamic instability, shock, and hypotension. Next, we can see submassive pulmonary embolism. In submassive pulmonary embolism, the patient will be like stable blood, and the blood pressure will be like stable, and the right ventricular dysfunction we can see. Next one, low risk pulmonary embolism. In low risk pulmonary embolism, the patient will be unstable and no right ventricular strain. Okay. Next, we have some causes. We covered already about the causes will be like because of we have a mnemonic. Think clot. T means trauma, hormonal therapy, immobility, neoplastic or cancer. K means knee or hip surgery. C means central venous catheter. L means long travel. O means obesity. T means thrombophilia. So this is the main common causes we can see here. Okay, and some moderate risk factors also like heart failure, obesity, smoking, OCPs, and increasing age. These are the patient most risk factors we can see. Next, clinical features of pulmonary embolism. If you are seeing clinical features, first of all, the patient we can see we have classical triad for pulmonary embolism. The classical triad we can see like dyspnea, difficult in breathing, chest pain, pleuritic chest pain, retrosternal pain patient will get. Then after patient will get another one, that is another symptom, that is hemoptysis. Okay, and we have some other symptoms like sudden shortness of breath, cough, and hemoptysis, and dizziness, and syncope if patient getting failure in right heart. Okay, right ventricular. Next, we can see some tachypnea, tachycardia, hypoxia, pyrexia, elevated jugular venous pressure, and gallop heart rhythm, and widely split second heart sound murmur we can see. Okay, S2 split we can see, and tricuspid regurgitation and murmur. Whenever patient getting second S2 heart sound split, we have to think about pulmonary embolism and atrial septal defect. Okay, and patient will get pleural rub and systemic hypotension and cardiogenic shock and massive pulmonary embolism. In mild cases, we can see fever also. Okay, so in physical examination, whenever patient coming with pulmonary embolism, we have some For in OPD, we have to check with proper history. Then after we have to go with physical examination. In physical examination, we have to do general inspection. Then after we have to check cardiovascular system, like the patient present with tachycardia, hypertension, raised GVP, and loud P2 sound we can listen. Okay, hypertension mostly because of massive pulmonary embolism, we can see hypertension. Next, we can see respiratory failure. In respiratory failure, we can see tachypnea and low oxygen saturation and clear lungs often. Next, we can see some signs. If patient have DVT, history of DVT, we can see unilateral leg swelling. We can see another one, cough, tenderness, and the Homan's sign will be like positive. Along with that warm sensation, we can see. Okay, so how we are going to classify that severity based on massive pulmonary embolism, intermediate risk pulmonary embolism, and low risk pulmonary embolism. In massive pulmonary embolism, we can see shock and hypertension. In intermediate risk pulmonary embolism, we can see right ventricular dysfunction and elevated biomarkers. Next, we can see low risk pulmonary embolism like stable patients. Okay. So next, we can see some how to do that investigation. Now, investigation. In investigation, normally we have to do some initial test with blood checkup. In blood checkup, we can go with some blood test like routine blood checkup, like D-dimer test we have to do. It will increase the sensitivity. Okay, so why the D-dimer test? What importance? D-dimer will help marker of clot breakdown. Okay, so it will help to break that clot. Okay, the normal value we can see around less than 500 nanogram per ml. The main use of it's good for ruling out pulmonary embolism in low risk patients. If patient have pulmonary embolism in low risk, then we can do D-dimer. The main limitations will be like if patient have any it's increased in pregnancy, infections, and cancer and old age patients. Okay, but it's reduced specificity, and we have to do troponin and BNP to BNP protein level and BNP troponin level and BNP levels may also be elevated if their patient have any heart strain because of pulmonary embolism. Okay, and next we have to do ECG. In ECG, mostly normally patient will present with sinus tachycardia. Along with that, in ECG we can see sinus tachycardia and atrial fibrillation and non-specific ST or T wave abnormalities, and we can see right ventricular strain pattern like V1 to V3, and we can see right axis deviation and right bundle branch block also, or S1Q3T3. S1Q3T3 means mostly we have to focus on this V1, V2 and V3. In this V1, V2, T3, we can see first one S1. Okay. So S1 you can see, and here in Q3 we can see Q3. Then after here we can see T3. Okay, like that we can diagnose the pulmonary embolism. Then after we have to do chest X-ray. In chest X-ray, usually it will show reduced vascular markings we can see in chest X-ray, and small effusion and wedge-shaped area of infection, and it mainly useful to exclude other chest disease and often normal. Okay, next we can do ABG. In ABG, the patient will get it may show hypoxia and type 1 respiratory failure, and in ABG we can see hypoxemia and respiratory alkalosis. Next we can see pulse oximetry, the saturation will reduce. Okay, so here we have to know some normal parameters for checking for diagnosing pulmonary embolism. The main heart rate we can see around 60 to 100 beats per minute, that is normal value. The respiratory rate 12 to 20 beats per minute, breaths per minute. The saturation will be like 95 to 100%. The partial oxygen we can see 75 to 100 mmHg, and partial carbon dioxide will be like 35 to 45 mmHg, and the pH we can see 7.35 to 7.45. Okay, so next we can do some echo test. It will help to rule out right ventricular strain and right ventricular hypokinesis. Next, we can do CTPA, computerized tomography pulmonary angiogram. This is very important. This is the main gold standard test for ruling out pulmonary vasculature to identify pulmonary embolism. You can see this type of structure here. I'm marking. You can see this type of markings. You can see, we call that is pulmonary embolism. In pulmonary embolism, it will show saddle embolus sitting across main pulmonary arteries. Okay, so that's why it's very important. And this is gold standard imaging test to filling defect. It will show to filling defect in pulmonary arteries, and it will locate the embolus, that spot. Next, we can do some other test we call VQ scan, means ventilator perfusion scan. Ventilator perfusion scan. This ventilator perfusion scan is main used when contrast patient have any contrast allergy or renal failure or pregnancies. In selected cases, we can do ventilation perfusion. Okay, so next we can do pulmonary angiography. That is the main gold standard test. We already saw this thing for checking invasive, for checking pulmonary embolism. Okay, so whenever patient coming with pulmonary embolism, how to approach that patient, how to diagnose that patient. So we have one criteria. Whenever patient coming with pulmonary embolism, what we have to follow? We have to follow this thing. If you suspect patient have pulmonary embolism, we have to assess with Wells score. What it means, we will discuss later. Wells score, it will help to know the probability. Okay, if it's low probability, then the D-dimer test we have to do. If the D-dimer test is positive, then we have to go with CT pulmonary angiography. Then at last we have to confirm the pulmonary embolism. Okay, so this is the thing. Wells score we have to check. If it's low probability, we have to go with D-dimer test. If D-dimer is positive, then only we have to go with CT pulmonary angiography. Then we have to confirm pulmonary embolism. Okay, this is the main thing. Next, we can see Wells criteria. So in Wells criteria, we have, okay, we called Wells score. This Wells score, we have two different levels of Wells score. In this Wells score, what are the things we are seeing? First, if patient have any clinically suspected DVT. If patient have means, we have to give 3 points. If pulmonary alternative diagnosis less likely than pulmonary embolism, then 3 points we have to give. If heart rate more than 100, then we have to give 1.5 points. If patient like immobilized greater than 3 days or surgery less than equal to 4 weeks, we have to give 1.4 points. If it's a history, patient have previous history of DVT or pulmonary embolism, we have to give 1 point. If it's patient have hemoptysis, we have to give 1.0 points. Next, if patient have malignancy, we have to give 1 point. Okay. Now we have to calculate these two levels of Wells score. If the Wells score less than 4, that means low probability is there, then we have to do dimer test. Then after it's normal, then we have to seek alternative cause. If it's raised, then we have to go with low molecular weight of heparin. We have to start. Along with that, we have to do CTPA to find out that spot of the pulmonary embolism. If patient have contraindicated to contrast CT and pregnancy, and patient have any renal failure problems, then we can go with ventilation perfusion scan. Okay, so next, if greater than 4% of greater than 4 points means, then we have to go with intermediate high probability, and we have to start low molecular weight heparin and CTPA ventilation and perfusion scan. Okay, so these are the things. Now, how to manage the patient with pulmonary embolism? The main management is to prevent clot extension and to prevent recurrence and to restore pulmonary circulation and to maintain oxygenation and to prevent death. So here in acute cases, we have to provide oxygen therapy. If patient have hypoxic supported therapy, then we have to provide more proper intravenous fluids carefully. Then after we have to check hemodynamically patient, we have to monitor. Then after we have to control the pain with analgesics. If patient is unstable, we have to send patient to ICU care. So in pulmonary embolism, first we have to start with heparin. Heparin, that is anticoagulant with subcutaneous low molecular weight heparin, we have to give, like tenjaparin 175 units per kg, enoxaparin 1.5 units per kg. So mostly here they are giving 5,000 international units or 2,500 international units. Based on patient condition, they are going to titre. So intravenous heparin is very important. Next, we can give thrombolysis, example like alteplase. If patient have any massive pulmonary embolism, in first line treatment for massive pulmonary embolism, the patient will get circulatory failure, patient have hypertension, then the CTPA we have to consider our echo, and pulmonary embolism severity index we have to follow. Then based on that outcomes and prediction, we have to do thrombolysis. Next, long term. In long term cases, we have to start warfarin. So we can start for long term, we can start warfarin, or a direct oral anticoagulation should ideally be commenced within 24 hours diagnosis. Examples like the drug of choice, double direct oral and anticoagulants we can use, like rivaroxaban, apixaban, and dabigatran. Once you started, then heparin we have to discontinue. Okay, so what is this? Rivaroxaban. Rivaroxaban is like a direct oral anticoagulants. 15 milligram BID we can give for 21 days. Then 20 milligram we have to change. Orally we have to give at least one time or 2 times per day we have to give. Okay, so the main duration we can give this drug for at least greater than 3 months. Greater than 3 months we can give. Along with that, if this is the main drug, will help to do stabilize the patient. Okay, so that is the main drug, and we have to avoid, in patient have renal failure, we have to avoid this drug. Second one, we have to go with apixaban. Apixaban means it's like same to same DOAC, 10 milligram twice daily we have to give for 7 days. Then we have to titre with 5 milligram twice daily. Okay, orally we have to give 2 times we can give, greater than equal to 3 months we can use. It will help, it will stable the pulmonary embolism. The important, it will no routine monitoring is we don't need. Next we can go with dabigatran. Dabigatran is the drug. It will act like same to same like DOAC drug. Once we started, we have to stop heparin. Okay. Next, heparin should be continued with warfarin, however, for 5 days until INR is therapeutic range 2 to 3. So we have to start. We have to continue heparin with warfarin for 5 days. If the INR comes to 2 to 3, then we can stop. Okay. In some cases, example like in a patient with active cancer, low molecular weight, heparin should be used for long term instead of warfarin. And the length of treatment depends on whether the pulmonary embolism is provoked, like unprovoked or recurrent. So we have total 4 different types of pulmonary embolism things we can see. First one, provoked pulmonary embolism. We have to start warfarin or drug of choice or DOAC for 3 months we can use. In this 3 months, we have to assess risk of benefits of extending treatment. Unprovoked pulmonary embolism, we can use warfarin or DOAC for 6 months and rule out underlying cancer. Next we can see recurrent pulmonary embolism, the lifelong warfarin or DOAC. Patients with active cancer, low molecular weight, or for 6 months the patient have to use. So whenever patient have pulmonary embolism, if patient is stable, we can prefer apixaban or rivaroxaban or low molecular weight heparin followed by oral anticoagulant. If in second line treatment, we can use for long term warfarin or UFH heparin we can use. Is preferred in pregnancy and severe renal impairment and need rapid reversal. And thrombolytic therapy for massive pulmonary embolism, the main features will be like shock, persistent hypotension, and severe right ventricular strain. The drug will be like we can use alteplase. So severity based on mild, moderate, and severe. In mild cases, we can start oral anticoagulation, early discharge possible, and follow up. Next one, moderate. In moderate cases, we can start anticoagulation, monitor right ventricular function, and hospital observation. In severe cases, we can see ICU admission, oxygen ventilation support, and thrombolysis, and we have to consider surgical embolectomy. Okay, so the patient mostly, what are the complications the patient can get with pulmonary embolism means? In early cases, sudden death, right ventricular, right heart failure, shock, and arrhythmia. In late cases, we can see chronic thromboembolic pulmonary hypertension and recurrent pulmonary embolism and reduced exercise capacity. For follow-up, we have to monitor clinical symptoms like dyspnea, improving or not, exercise intolerance, and chest pain. And laboratory, we have to do follow-up like CBC, renal function, and INR if you are using warfarin. And we have to use imaging for echocardiography if persistent symptoms. Okay. So these are the things. If you are doing any internal medicine and rotation exam or ASCII settings, the doctor can ask some this high yield points. Like tell me the most common source of pulmonary embolism, that is DVT from lower limb femoral vein. Gold standard imaging for pulmonary embolism, that is CTPA. The most common ECG findings we can see, that is sinus tachycardia. And the classic ECG sign we can see, that is S1, Q3, T3, not always present. In early cases, we can't see this thing. Next, we have to do D-dimer test. The D-dimer test will rule out the patient's pulmonary embolism in low risk patients. Massive pulmonary embolism treatment is, the main thing is thrombolysis. Anticoagulation duration, we have to use at least 3 months. Okay. If this video is helping you, please like, share, and subscribe. You can share with your friends. And if you want to cover any important topic, you can message me in comment section. You can follow me through Telegram, Medsteps Medical Education, in Instagram, Dr. Anandjana. Okay, so that's all. I covered everything. So we will meet in our upcoming videos. Till the time, signing off, Dr. Anandjana.